Welcome to this video on beta blockers. Beta blockers may be broadly classified into three generations. The first generation beta blockers are non-selective. They block both beta 1 receptors and beta 2 receptors. The second generation beta blockers are selective for beta 1 receptors. They are also called cardioselective because of their selectivity for beta 1 receptors. Third generation beta blockers may be broadly classified into two: the non-selective third generation beta blockers and the selective third generation beta blockers. So these are again selective for beta 1 receptors or cardioselective. Each of these groups are further subclassified into those with number 1, membrane stabilizing activity, otherwise called local anesthetic activity. Number 2, those with additional alpha blockade. Number 3, those with partial agonistic activity, otherwise called intrinsic sympathomimetic activity, and others. Now, the first generation or non-selective beta blockers. As we mentioned, these can be further subclassified into those with membrane stabilizing activity, additional alpha blockade, partial agonistic activity, and others. Now, the ones that have got membrane stabilizing property include propranolol and pindolol. Those with partial agonistic activity include allopurinol, penbutalol, pindolol, and oxpranol. Others in this group include timolol and nadolol. Now, the second generation or cardioselective beta blockers, again classified into those with membrane stabilizing activity, those with additional alpha blockade, partial agonistic activity, and others. Now, those with membrane stabilizing activity include acebutolol and metoprolol. Those with partial agonistic activity include just one example, again acebutolol. Others in this group include atenolol, bisoprolol, and esmolol. Now, the third generation non-selective beta blockers are relatively easier to memorize. So let's move on to the cardioselective third generation beta blockers. Now, these include betaxolol, which has got membrane stabilizing property. The one which has got partial agonistic activity includes celiprolol, and others in this group include nebivolol. The third generation beta blockers which are non-selective, those with membrane stabilizing activity include labetolol and carvedilol. Those with additional alpha blockade include labetolol and carvedilol again. Those with partial agonistic activity include labetolol and at this time cardiolol, and others in this group include bucindolol. So this is how beta blockers are classified. There are many uses for beta blockers: the cardiac uses and the extracardiac uses. The cardiac uses are many. They include mitral valve prolapse, supraventricular tachycardias, and a host of other cardiac arrhythmias, congestive cardiac failure, stable ischemic heart disease, hypertension, and hypertensive emergencies both in non-pregnant patients and in pregnancy, acute coronary syndrome, emergency treatment of the tetralogy of Fallot, and many others. The extracardiac uses include prophylaxis of rupture of esophageal varices, prophylaxis of migraine, performance anxiety, pheochromocytoma, glaucoma, hyperthyroidism, akathisia, and tremors, as long as they are not tremors associated with Parkinson's disease. Okay, so let's move on to the cardiac uses, some cardiac uses of beta blockers. Right off the bat, I would like to make this point clear that drugs with beta blockers with partial agonistic activity, otherwise intrinsic sympathomimetic activity like pindolol, are not recommended for the treatment of hypertension or, for that matter, any cardiovascular disease. The reason for this is that they increase the nighttime mean heart rate due to their direct partial agonistic activity. Right. Let us now try to make sense of the role of beta blockers in heart failure. A beta blocker can behave as a different drug in different situations. This feature of beta blockers becomes very important in heart failure. For the purpose of this discussion, heart failure may be considered as a chronic, progressive condition in which the heart struggles to maintain a sufficient cardiac output. As the disease progresses over a period of months or years, acute exacerbations get precipitated from time to time. Now, let us consider a situation where a patient has got a healthy heart and a beta blocker is started for that patient at full therapeutic dose. We know very well that beta blockers are going to decrease the force of contraction and therefore reduce the cardiac output. This is because beta 1 receptors are present in the heart, and upon blockade they will reduce the force of contraction of the heart. Now let us consider a situation where the heart is failing, but where compensatory mechanisms are somehow maintaining a cardiac output, a reasonably normal cardiac output. So this is what we call chronic compensated heart failure. Now in such a patient, if we started that patient on a full therapeutic dose of beta blocker, again what we can expect is negative inotropy. But if we started the same drug at 1/8 of the full therapeutic dose and then double the dose every 4 weeks and continue doubling until full therapeutic dose is achieved, what we can expect is an increase in cardiac output within 3 to 6 months of such therapy. And in such a condition, beta blockers are positively inotropic. Now, not all beta blockers are suitable for chronic compensated heart failure. There are only 4 beta blockers that are indicated for the use for the treatment of chronic compensated heart failure, and they include carvedilol, bisoprolol, the prolonged release form of metoprolol, and nebivolol. Now finally, let us consider a patient with a failing heart, but where this time the compensatory mechanisms have failed to maintain the cardiac output. Now this is acute decompensated heart failure. This is an acute exacerbation. Now, irrespective of the dose, beta blockers are negatively inotropic in this condition. And if the patient was on a beta blocker, then it should be temporarily withheld until the patient becomes stable and reinitiated later at a very, very low dose and slowly up-titrated. Thus, beta blockers are indicated as first-line drugs in the treatment of chronic compensated heart failure. However, they should be withheld in acute exacerbations of heart failure, otherwise called acute decompensated heart failure. Out of the 4 beta blockers that are commonly used in the management of chronic heart failure with reduced ejection fraction, 3 are cardioselective, and they include bisoprolol, metoprolol, the prolonged release form of metoprolol, and nebivolol. One of these is non-selective, and that is carvedilol. Now, carvedilol is non-selective, however, it has 3 other important properties. As we saw earlier, it also blocks alpha-1 receptors and is therefore vasodilatory. It has both antioxidant and anti-inflammatory properties as well. Hence, in spite of not being cardioselective, Carvedilol is considered by many experts to be the beta blocker of choice in chronic heart failure with reduced ejection fraction. Now, let us try to understand the role of beta blockers in ischemic heart disease. Obviously, we'll have to understand what ischemic heart disease means to begin with. Now, ischemic heart disease, to oversimplify, is a condition where there is either a decrease in the myocardial oxygen supply or an increase in the myocardial oxygen demand, or a combination of both. This ischemia leads to chest pain. Chest pain of this etiology, which occurs only on exertion, is called stable angina. On the other hand, chest pain of this etiology, which occurs even at rest, is called unstable angina. If the ischemia leads to death of any portion of the cardiac tissue, then the situation is called a myocardial infarction. Myocardial infarctions can generally occur in two ways depending on whether the ST segment in the ECG is elevated. If it is not elevated, we call it a non-ST elevation myocardial infarction, otherwise called an NSTEMI. And if it is elevated, we call it an ST elevation myocardial infarction, or STEMI. Guidelines on the management of ischemic heart disease often classify ischemic heart disease into management of stable ischemic heart disease and management of acute coronary syndrome. Stable ischemic heart disease includes both stable angina and low risk unstable angina. Acute coronary syndrome includes the management of non-ST elevation ACS and management of STEMI. Management of non-ST elevation ACS includes high risk unstable angina and NSTEMI. Management of STEMI obviously would include just the management of ST elevation MI. Now, beta blockers have distinct roles to play in stable ischemic heart disease and acute coronary syndrome. So, what is the role of beta blockers in stable ischemic heart disease? Beta blockers reduce the heart rate and the contractility. It is negatively chronotropic and inotropic. This will reduce the myocardial oxygen demand and makes beta blockers very useful in stable ischemic heart disease. However, by reducing the heart rate and the contractility, there is a chance that beta blockers could increase the amount of blood in the left ventricle at the end of diastole, that is the left ventricular end diastolic volume. This can lead to an increased left ventricular wall tension and therefore potentially an increase in myocardial oxygen demand. This is why beta blockers in stable ischemic heart disease is always combined with nitrates. Nitrates at low doses cause preferential venodilatation. This reduces the blood that returns to the heart and therefore reduces end diastolic volume and therefore left ventricular wall tension. The main adverse effects of nitrates will be reflex tachycardia. By combining nitrates with beta blockers, they more or less negate each other's adverse effects, and therefore the combination of beta blockers and nitrates is highly effective for stable ischemic heart disease. Now, in the case of acute coronary syndrome, patients who survive an acute coronary syndrome are often prescribed beta blockers, and this is true even if they do not have any comorbidities like hypertension or heart failure. They may not have any past history of arrhythmias, and they may not be even currently suffering from any arrhythmia. Then why administer beta blockers to these patients? Post myocardial infarction, there is a mortality of up to 5 to 15% in the first year, and most of these deaths can be attributed to the sudden development of deadly arrhythmias in the infarcted cardiac tissue. Beta blockers are the best antiarrhythmics to reduce post-MI mortality. Early institution of beta blocker therapy, continued for at least 6 years, is recommended for all patients surviving an MI unless contraindicated. Beta blocking drugs exert their antiarrhythmic effects post-MI by blunting the arrhythmogenic effects of catecholamines. Beta blockers are the only drug class that is effective in reducing the severity and frequency of attacks of exertional angina and in improving the survival in patients who have had an MI. They are therefore recommended as first-line treatment of patients with stable ischemic heart disease and post-acute coronary syndrome. It is recommended that the beta blocker dosing be adjusted to limit the heart rate to 55 or up to 60 beats per minute at rest. And now we move on to beta blockers in hypertension. How do selective beta blockers reduce blood pressure? Well, we know that beta 1 receptors are present in the juxtaglomerular apparatus of the kidneys, and when we block these receptors, there is a fall in the renin, angiotensin, aldosterone activity, and this results in a reduction in the total peripheral resistance and a reduction in the cardiac output, a modest reduction in the cardiac output. We also know that they block beta 1 receptors in the heart. This causes a decreased cardiac output, and we know that blood pressure is essentially cardiac output multiplied by total peripheral resistance. So by reducing these two entities, we can reduce the blood pressure. The current view regarding beta blockers is that there is inadequate evidence to support the initial use of beta blockers for hypertension in the absence of specific cardiovascular comorbidities. This is why they are no longer considered as first-line drugs in the absence of specific cardiovascular comorbidities. Now let's take a look at the role of beta blockers in hypertensive emergencies. There are two beta blockers that are used in two distinct forms of hypertensive emergencies. In perioperative hypertensive emergencies, we use esmolol, and in pre-eclampsia, which is the hypertensive emergency in pregnancy, we use Labetolol. Perioperative hypertension is defined as a BP of 160-90 millimeters mercury or higher, or a systolic BP elevation of at least 20% of the preoperative value that persists for longer than 15 minutes. Esmolol is suitable for this condition. Now, in hypertensive emergencies in pregnancy, Labetolol should be given by the IV route. Decreases in blood pressure are observed after 5 minutes, which is very desirable in a medical emergency such as this. We give Labetolol at a dose of 20 milligrams, followed by the second dose of 40 milligrams. The third, fourth, and fifth doses would be 80 milligrams. Labetolol should be given up to 5 doses intravenously, and each dose should be administered 10 minutes apart, and the total dose should not be more than 300 milligrams in pre-eclampsia. Regarding the use of beta blockers in the prophylaxis of migraine, the mechanism of action of beta blockers in prophylaxis of migraine is still under investigation, but it is quite clear that it is a first-line drug with high efficacy in the prophylaxis of migraine. Now, regarding the use of beta blockers in glaucoma, beta blockers in glaucoma can be classified broadly into two, non-selective and selective beta blockers. The non-selective beta blockers used in glaucoma include metipranolol, not metoprolol, metipranolol, levobunolol, carvedilol, and timolol. The selective beta blocker available is betaxolol. Beta blockers are useful topically in glaucoma by reducing the production of aqueous humor. How exactly it reduces the production of aqueous humor is still under investigation. Now we need to know the situations where non-selective beta blockers are generally avoided. These include peripheral arterial occlusive disease, asthma, diabetic patients, especially those on insulin, and dyslipidemia. In general, beta blockers are contraindicated in patients with peripheral arterial occlusive disease. However, there are two beta blockers which are actually effective in the treatment of peripheral arterial occlusive disease. They include Carvedilol and Nebivolol. Again, in general, beta blockers are contraindicated relatively in patients with asthma. However, there is one beta blocker that can be again relatively safely given in patients with asthma, and that is bisoprolol. It's worth noting that as far as possible, diabetic patients on insulin should not be started on a beta blocker. The most serious adverse effect of insulin is hypoglycemia, which is potentially fatal. Hypoglycemia can present with some warning symptoms such as tachycardia, tremors, and so on. However, a patient on beta blockers would not experience any of these symptoms. In other words, beta blockers can mask the symptoms of hypoglycemia. This could obviously result in a delay in the diagnosis with potentially fatal consequences.